Alright, so I'm going to be doing my presentation on restrictive cardiomyopathy. Um, Restrictive cardiomyopathies is a heterogeneous group of cardiac muscle conditions that all show um, common symptoms of heart failure. You'll see diastolic dysfunction with preserved systolic function on an echo and majority of the time, but you can also have systolic dysfunction, which could play a role in some specific pathologies. The majority of restrictive cardiomyopathies are secondary to a systemic disorder like amyloidosis or sarcoidosis or scleroderma. And the list kind of goes on. It is usually diagnosed based on medical history, physical exam, and tests like blood work, EKG, echoes, chest x-ray, MRIs. Um, and with its wide availability, the echo is probably the most important investigation to be able to identify this left ventricular dysfunction. Um, so, Restrictive cardiomyopathy is the least common type of cardiomyopathy there is, and doesn't really have an accepted diagnostic criteria, I guess. It's usually has increased stiffness of the myocardium that causes an increase in ventricular pressure with only a small increase in volume. So, ventricular diastolic volumes are usually normal or lower, and wall thickness is normal or mildly increased, and systolic function is the same. The classic features are small ventricle um, with a marked atrial dilatation and normal systolic function without pericardial disease. And this all causes there to be normal systolic contraction with a quick but not sustainable ventricular filling, and you can see this on a pulse wave Doppler. And this pattern is usually is typically restrictive physiology summed up, which kind of correlates the dip and plateau contour of early diastolic pressure traces. So as far as the types of restrictive cardiomyopathies, the purest form is idiopathic restrictive cardiomyopathy, and restrictive hemodynamics have been described in a lot of different ways that affect the heart, which increases variety of phenotypes that are grouped under this umbrella of restrictive cardiomyopathies. And the most common out of all the diseases is the cardiac amyloidosis, which is an infiltrative systemic disease that can sometimes affect the heart, leading to an increased myocardial stiffness and a restrictive filling. Another condition that can lead to restrictive cardiomyopathy is the eosinophilic endomyocardial disease, and other infiltrative disease like hemosiderosis or sarcoidosis or scleroderma may also lead to the restrictive cardiomyopathy. And the fact that an etiological factor and a specific pathological process have been documented in both cardiac amyloidosis and endomyocardial disease makes them secondary restrictive cardiomyopathies. And I guess I just wanted to kind of talk about really quickly two different types cardiomyopathies. So here we have just cardiac amyloidosis, which is the most common cause of restrictive cardiomyopathy, and vast majority of the literature refer to cardiac amyloidosis when describing restrictive cardiomyopathy. So, however, this causes both diastolic but also systolic left ventricular dysfunction, more often seen in, I would say, mild dilated cardiomyopathies. And when the heart is involved, interstitial infiltration of the atria and ventricles leads to a firm, kind of rubbery consistency of the myocardium in probably the most severe cases. Systemic amyloidosis is a disorder of protein metabolism in which abnormal extracellular protein material is deposited in organs and tissues, and it causes morbidity, and it's typically fatal. And the heart is often involved in like a light chain amyloid, which leads to CHF. Then we also have the idiopathic restrictive cardiomyopathy. This is the most pure way to really diagnose restrictive cardiomyopathy is using a hemodynamic criteria, supported by the absence of specific pathology in either endomyocardial biopsies or evaluation of the whole heart specimens. So patients in severe heart failure, the atria are usually disproportionately dilated, and the left ventricle has is normal or near normal systolic function. Histology is normal, normally non-distinctive or non-specific degenerative changes like myocyte hypertrophy, disarray, and interstitial fibrosis. And when disarray is actually present, some form of hypertrophic cardiomyopathy needs to be considered. So in an article that I read, they showed that restrictive cardiomyopathy is not a single entity, but is a heterogeneous group of disorders that can present with a spectrum of cardiac phenotypes, including HCM, dilated cardiomyopathy, or left ventricular non-compaction. And mutations in sarcomere protein genes are an important cause of idiopathic restrictive cardiomyopathy. Now, just to kind of quickly go over restrictive physiology, you have an increased ventricular filling pressures with the typical dip and plateau pattern, or the hemodynamic hallmarks of restrictive cardiomyopathies, and atrial pressures will go above 50 millimeters of mercury. Right atrial pressure typically greater than 7 millimeters of mercury, and pulmonary capillary wedge pressure typically more than 12 millimeters of mercury. In contrast with the equalization of left and right sided diastolic pressures and constrictive pericarditis, diastolic pressures are separable by more than 5 millimeters of mercury in restrictive cardiomyopathy due to the unequal involvement and compliance of the two ventricles. However, in restrictive cardiomyopathy, this separation isn't really seen at baseline unless the patient is very active doing like leg raises, exercise, there's some kind of volume loading or pharmacological intervention. In patients with restrictive cardiomyopathy are either due to cardiac amyloidosis or endomyocardial fibrosis, show a spectrum of pattern to a milder form of abnormal relaxation with a long isovolumic relaxation time and decreased rate of acceleration to the low early peak velocity. Now just to kind of talk about the differences between the restrictive cardiomyopathy and constrictive pericarditis real quick. Most of the time it's easy to tell the difference between the two based on the appearances of the left ventricle. Restrictive cardiomyopathy shows a clinical and hemodynamic picture that is often indistinguishable from constrictive pericarditis. And when you're trying to differentiate them, it's very, very important because constrictive pericarditis, it can be curable by doing a pericardial resection, whereas restrictive cardiomyopathy isn't. So normally there's an interdependence between the right ventricle and left ventricle during the respiration, as the pericardium transmits the intrathoracic pressures to the intrapericardial and intracardiac chambers. During inspiration, there's a drop in intrathoracic pressures, which will be transmitted to the intracardiac chambers with a parallel drop of pulmonary capillary and left ventricular diastolic pressures, keeping the transmitral and transtricuspid diastolic gradients unchanged. An increase of venous return and a slight increase in right ventricular size. In constrictive pericarditis, the pericardium is thickened, forming a shell around the heart, so the drop in intrathoracic pressures won't be transmitted to the intracardiac pressures. So the systemic venous and right atrial pressures will not fall during inspiration, and transmitral gradient will be dropped as opposed to transtricuspid gradient, which should be increased. And consequently, during inspiration, the transmitral velocities will be reduced and tricuspid velocities increase in constrictive pericarditis, whereas restrictive cardiomyopathy will remain unchanged. And that's pretty much it for that. And these are my references. I just kind of want to say that while it's convenient to classify cardiomyopathies into groups, there is an overlap between the anatomic and functional characteristics a lot of times, and echoes are currently the best imaging modality to help tell them apart. Um, and a lot of times cardiomyopathies have a familial nature, and it's really important to kind of screen the family members as well, as often the diagnosis may be more revealing once the family screening has been done. And yeah, that's it. Thanks for listening.